Welcome to this presentation where I propose Dementia Affirmative Gender, Sex and Relationship Diverse Therapy, or DA-GSRD therapy for short, as an approach for counsellors and psychotherapists from all therapy modalities working with GSRD people impacted by dementia. While this way of working can be used for any GSRD people impacted by dementia, the brevity of this presentation means I've focused a little more on an introduction to working with partners of GSRD people living with dementia. The DA-GSRD model is very much influenced by GSRD therapy as developed by Dominic Davis and Silver Neves. GSRD therapy has 7 main elements, as shown here, and I'll touch on each of them. I found nothing in the literature directly related to working therapeutically with GSRD people impacted by dementia, so my work has been in adapting from allied research. My adaptation of this material into a proposed approach is shaped by my lived experience of journeying with my late partner through her dementia in our long-term cisgender lesbian monogamous marriage. It's also shaped by my ongoing professional work as an emotionally focused therapist, supervisor and trainer with a particular focus on EFT with LGBTQ+ people. And last but far from least, my training in GSRD therapy with pink therapy. It's impossible to know how many of the 50 million people in the world living with the diagnosis of dementia are GSRD, and so we cannot know the number of their partners either. However, there's no reason to believe that GSRD people have dementia at a lower rate than non-GSRD people, and some research suggests an increased rate. For example, Westwood and Price describe how the stresses and strains of living as an LGBTQ+ person may increase the risk of dementia and may also increase the challenges of living with dementia. The first theme I'll look at is practicing a commitment to social justice. In one of the few books about dementia and psychotherapy, Cheston talks about how it is important to understand that the impact of dementia does not simply depend on the extent to which a person is affected neurologically. Rather, the context in which people live will at least in part determine how they experience dementia, because it is this wider social context that determines what sorts of support are available, from whom, and when they are likely to access this. And context includes being GSRD. Knocker, for example, describes how core being lesbian, gay, or bisexual may be to a person's sense of self. It is more than a person's sex life. It shapes the way you have experienced life, your interests, likes, dislikes, humour, friendships, attitudes. It is therefore part of assessing people's social interests and cultural needs, as well as their social contacts and relationships. A care plan that neglects to include this huge part of a person's individuality is clearly incomplete and is likely to fall short of meeting that person's needs. And services working effectively with GSRD people impacted by dementia does mean doing some things differently. As June said, we don't want to be treated the same because you're saying the same is assuming that we're heterosexual. So actually, I do want to be treated differently. A DA-GSRD therapist can have an important role inside and outside the therapy room in increasing awareness, inclusion and integration of GSRD people impacted by dementia in all their intersectional identities, in dementia spaces and in GSRD spaces, and in those rare GSRD dementia spaces. They can be a supportive ally and perhaps an active accomplice in dismantling this inequality and oppression. Another theme of GSRD therapy is integrating core GSRD theories, and in DA-GSRD therapy, person-centered approaches to dementia and disability justice would also be included. At the heart of GSRD therapy is working affirmatively, and it has much to offer, as dementia is often viewed from a deficit model, or as Lipinska puts it, all experiences of living with dementia are negative and based on disintegration, degeneration, and diminishment. Although this may be one person's experiencing, there is also the person who sees this condition as another of life's challenges and is determined to make the best of it all. DA-GSRD fits with the person-centered approaches to dementia, which have moved away from pathology and towards the person with dementia. Moe and Pope describe how affirming practitioners don't assume that LGBTQ+ identities and experiences are rigid or static, nor that they are the primary or most salient aspects of personal identity for all clients who experience or express them. Similarly, DA-GSRD therapists wouldn't assume that dementia and/or being GSRD are rigid or static, or the primary focus, ongoing, of their clients. They will explore, affirm, and expand positive aspects of the impact of dementia and work in an attuned way as aspects of identity and experience shift, including the impact of increased dementia symptoms. Let's turn now to demonstrating cultural humility and cultural competence. A DA-GSRD therapist will focus on the individual experience of their client, in this case a partner or partners of a GSRD person with a diagnosis of dementia, being aware of the huge diversity within that group of people and the concentration of much of the very limited literature on gay men and lesbians, and so much less on others, for example, trans and bisexual people, and those who are ethically non-monogamous. Alongside this, they'll have learned about dementias and about common experiences GSRD people with dementia and their partners may have, and they'll bring in this learning as appropriate to support their clients. Cultural humility includes ongoing self-reflexivity and working through internalized prejudices and assumptions. For the DA-GSRD therapist, this would particularly include those concerning GSRD people, those with dementia, carers, older people, and the intersection of these. There is so much that could be said in this section on understanding the specific adverse effects of oppression, and indeed in all the sections. I'll just touch on one theme here, navigating coming out as GSRD in care settings. Dealing with health professionals and carers as an outpatient in their own home and in residential care as an out GSRD person is to be vulnerable to mistreatment, discrimination, and oppression, as well as open to support, understanding, and affirmation. Research studies have consistently found that older GSRD people fear needing residential care because of how they may be treated, and indeed there are many examples of mistreatment, along with some positive examples. A decision to come out to one person is likely to be documented and be available to anyone reading those notes. It should be written into care plans for effective care, but that also means it may be available to those the person with dementia and their partner may not want to know. For some GSRD people, this will include the person with dementia's biological family. Coming out is complex. As Trace says, it is an ongoing dynamic process. Every unfamiliar person and place, such as a hospital or nursing home, demands yet another decision about disclosure. Many things will affect the decision, not just the attitudes or perceived attitudes of staff and of other patients or residents, but also the expectations based on past experience which the individual brings to the situation. Research tells us that LGBT people with dementia and their partners don't routinely disclose that they are LGBT to health service professionals, and that getting indicators that they will be accepted, included, and/or welcomed help in coming out. Some people, particularly those who are trans or non-binary, may have no choice but to come out because of specific bodily and intimate care needs. Different research reveals that for some people, their GSRD identity is crucial to their sense of self and may be explicit in how they present themselves. They may have been out in all aspects of their lives for many years, and they may continue this through into care settings. Others may feel so fearful of discrimination that they go back in the closet for the first time in decades. Some consider that being GSRD is not such an important part of their identity and feel safer not to share it, especially if they are single or in an opposite-sex partnership. Some may not have been out much in their lives, but decide that it is important to say as they go into residential care. And in some cases, the residential care has felt so supportive that they are able to come out to themselves and others for the first time in their lives. Partners of GSRD people with dementia may take on some or all of proactively managing any disclosure of being GSRD to service providers. This will often mean, as Newman and Price say in relation to lesbian and gay carers, their interactions with providers are, as a result, overlaid with a pervasive anxiety around how those disclosures will be responded to and shared. Challenges in managing disclosure may be increased by differences between the person with dementia and their partner or partners on whether to come out or not, or having decided not to come out, the impact of dementia on a person may lead to them talking about that being GSRD in a way they hadn't wanted. It may also be that the person with dementia becomes more afraid of being out as their dementia progresses, if it leads to them being more in the past, where there was more pathologization, criminalization, and oppression of GSRD people. The DA-GSRD therapist will need to understand the complexity and stress of the ongoing dynamic process that coming out is for a partner of a GSRD person with dementia, and support them in working through this. The next theme is being trauma, grief, and shame informed. There is obviously grief and loss as the relationship changes, and the GSRD partner's dementia has more and more impact. For the partners of GSRD people, there can be a fear and indeed reality of their relationship being forgotten and them no longer being recognised, and this can have an impact on how they experience themselves as a GSRD person. Flanagan and Pang give an example of a GSRD person sharing these concerns. What she operates is now definitely our pre-marriage days. It's almost like our 25 years is starting to go, and she'll substitute activities that happened many years ago, long before me, and put me into them, except I wasn't there, And so, how do you correct? And I pulled all the pictures together, hanging up little things in the kitchen and stuff, so that those images are present for her, because when she sees a picture, her memories are very clear, but without that stimulating. A DA-GSRD therapist will support their client or clients to, as Cheston puts it, live in the shadow of dementia. Here I will look less at sexology, though again that's an important theme, and more on intimacy and physical touch. Public displays of affection have been a common discussion theme in the LGBTQ+ literature, and they have a particular relevance in dementia care, especially in residential care, where loving looks, hand-holding, kisses and hugs may be received by both a GSRD person living with dementia and a partner as moments of recognition and sustainment of their loving connection. They may also need to take place in public, unless a partner is able to ask to go to a private room and that request be met. As one of Knocker's research participants, Hannah, said, "When I visited Jean in the home, she was always sitting in the main lounge with other residents. This made it more awkward for me to hold her hand or give her a cuddle. I didn't feel confident enough to ask the staff to move her to her own room so we could be alone for a while. I felt like I was in a goldfish bowl with all eyes and ears on us." Last but not least, the DA-GSRD therapist needs to foster joy, or at least anything other than only the consuming negative narrative about dementia. The strategy of one of Flanagan and Pang's research participants, a GSRD person with dementia, was for them and their partner to come to terms with their dementia by choosing how to live with it. You can make the choice to embrace the day and just do your very best, and that is what we have chosen to do. It's that desire to want to do my best every day that I think has helped my spirit. The diagnosis of dementia also has the potential to be transformative, with the person diagnosed deciding to invest themselves in savouring life and their closest relationships while they are able to do so. Thank you for listening to this brief presentation on my proposal of dementia affirmative GSRD therapy as an approach for counsellors and psychotherapists from all therapy modalities working with GSRD people impacted by dementia. Dementia and GSRD people is increasingly being researched and discussed, but there are still huge gaps, and specifically concerning transgender, bisexual, and ethically non-monogamous people, and in therapy for GSRD people impacted by dementia. I hope this presentation will promote more discussion and action.